Great. Thanks, panel members. Thanks, Greg, for inviting me to talk about some challenging cases. I wanted to try to copy some of Sanjay's great vibe that he had at his talk the other day. And one thing I learned, you gotta have the apple juice. So we have some apple juice for our panelists. And I also like the team approach. So nobody's going to be on the spot today other than maybe me for what I did, right? So disclosures, I am a medical advisor for Case Drive, and they're sponsoring the course today, and you probably met some of them outside. And all the patients have signed releases allowing their image to be shared for learning purposes. Going back to 2004 here, 20 years ago now, I don't know if you can spot the two familiar faces, sore losers, I guess. So that's me and Greg right in the middle there. And we were co-residents, and Greg's always been such a great, he was a great chief resident, and he's always been very supportive and inclusive, right? And he's created this great community of just about kind of the nicest, most knowledgeable, and like most humble rhinologists. So, and with that in mind, I think some of these digital tools such as Case Drive can really be the glue that holds this community together so that we're not just sharing our knowledge and experience while we're here, but potentially throughout the year by sharing cases. And I think we can submit cases really throughout the year and get feedback from our faculty members and other participants. So next year at SOAR, I don't want to do all this work next year. So next year, if you guys share all your cases, we're going to discuss them throughout the year and then also present them at the end of the year. And I'm going to offer up a bottle of I collect whiskey. I'm going to offer up one of my best bottles for the prize for case of the year. So on to the cases. So case one. So again, you can respond as a group here. So we have a 57-year-old man with progressive right greater than left-sided nasal congestion and loss of smell for about a year and a half. No asthma, aspirin sensitivity, and of course he responded to multiple 2-week courses of antibiotics and steroids. And with lab testing, he had some increased eosinophils and mildly increased IgE. So you look in his nose and it looks like this, okay? So let's look at the CT scan. Okay, let's get this going. And see if you guys collectively find anything interesting about the scan. You guys can shout at any time or nothing. All right, if no one says anything, I'll call on somebody. Aria, go.
Well, it looks like it's a right predominant sinusitis, and obviously there's a lesion when you're looking on endoscopy. I'm assuming that endoscopy was the right side. The lesion itself looks a little bit more mucosalized than I would expect for a polyp case alone. So I'm interested in kind of seeing potentially what it looks like on the left side. In terms of the inflammation. I'm certainly, highest on the differential would probably be something like CRS with nasal polyps, but I'm also thinking about other things that may have more of an asymmetric presentation, like AFRS, or maybe like sinonasal mass, or encephalocele, or something a little bit more unusual. There's something off about the way it's more so on the right than the left, I would
Certainly,
say.
yeah. I kind of stepped in it, yeah. So underwent routine FES with frontal sinusotomy, ethmoidectomy, anterior skull-base dissection, maxillary enterostomy, septoplasty. And then we saw this right greater than left side nasal polyps and this bulky right lesion with some bony septation. It's kind of this purulent-looking discharge. At this point, thinking mucopycele, infected concha bullosa, double middle turbinate. So I was operating at my remote site where there were no frozen available, but I did take a separate pathology of that bony lesion on the right, and we will take a quick look at what that looked like. So, and I also have a quick video here, but you can see there's this kind of this interesting bony septations there. Kind of this purulent sort of stuff came out, and it clearly went about as high as the Agranasi. And we'll take a little bit look at what that looks like. And you can see the septum there on the right. You can see what looks like a small atrophic middle turbinate, which was also taken during the surgery. You can just see where this, the superior limit of this lesion is, kind of up near the top there. Again, at the level of kind of the agar and then I think I show a little bit of the other side, but yeah, polyps on the other side, not too interesting. So.
And it was purulence that came out of that? Or
Well, it looked like, yeah, kind of
like more
liquidy, very liquidy, yeah. So patient did fine, got called the next day, glial contents. So Aria put that in the differential, but completely, in my mind, separate from the skull base. There was no connection. I did a full dissection, nothing. So the patient is at home in Indianola, for those of you who are from out of town. That's over in the Olympic Peninsula. So what do you tell the patient? What do you do?
there was no, there was no CSF at any point.
No, nothing. Do you take the patient back? Do you just rescan? Do you?
So one thing is that I had one case where on the initial pathology there was some concern that there was glial tissue in a very inflamed case, but there are markers that they can do to actually check if it truly is actually neural or glial tissue, and it was not on further staining. So one thing would just be to really make sure that the pathologist is confident in whether or not that was just like a small speck of something unusual.
Yeah, no, he said there was a lot.
A lot of tissue.
He said there was a lot. Yeah, any other thoughts what you'd do in this case? I mean, you kind of saw the skull. I felt I saw the skull base. It looked intact. I felt like I saw the superior extent of what this was.
Yeah, I mean, you'd be, thinking, could this be something ectopic? Obviously, the first thing you have to rule out is an encephalocele then. So making sure the patient is, intact and is recovering normally, all those types of things are going to be important. You could get another CT sinus post-op now and see to assess the skull base to see what's going on. And if they're recovering completely normally, I would, document the conversation, let them know signs and symptoms to watch for, obviously. Maybe even bring them in early to do an endoscopy for something provocative like a Valsalva under endoscopy to see if you can see anything. But obviously with that type of reading on the path, I think you're obligated from different perspectives to do something, right? I don't think if the patient says, I'm feeling okay, I would just let it go until you really rectify what the final conclusive pathologic report's going to read.
Anything out, Greg? Or?
Yeah, I think with the kind of the experience and the confidence to know that you were at no point anywhere near the skull base without postoperative CSF symptoms or signs, I would agree. I'd wait to get the final pathology. I wouldn't really accept just glial contents as the final pathology report. So I'd wait to hear what that is. But I agree. I think I'm a big fan of just, if anything is weird, just see the patient back early and see them back often. Bring them in, make sure you not only are they healthy and sleeping well, but you're sleeping well at night and that you're not missing anything.
Yeah. Say, okay, well, that's pretty much what I did. In the sense I called the patient. The patient was doing great. And he's kind of, and again, he was very loath to come back in. Again, it's not easy to get in. And he was actually pretty loath to get a repeat scan, but I talked him into it. Again, got the scan, no air, no skull base defect. I didn't show it here, but I can put it into Case Drive and show everybody. He did great. So any clue, I guess, Aria, you were suspicious of a encephalocele kind of right away. So what kind of clued you in? Because I missed it. I'm the dum-dum, okay?
I think, I always look in chronic rhinosinusitis or the routine types of patients that we see in our office. I look for symmetry, and it tends to affect the mucoperiosteal thickening tends to be symmetric on both sides, and whenever it's more on one side, I counsel the patient that we may encounter something like a fungal ball or something more unusual or something that may require additional treatment. In this case in particular, I felt like the middle turbinate. I also look at in a polyp case, I look at kind of that olfactory groove, that cleft, and the position of the middle turbinates, just because we know that there's a condition called central compartment atopic disease. I'd want to tease that out from the history, but anything that's coming from the medial aspect of the sinonasal cavity raises some suspicion to me for that. There was also quite a bit of inspissated secretions in the sphenoid. It wasn't quite chronic rhinosinusitis appearing at the throughout. There were some bubbly, frothy secretions in the frontal as well. So. Again, probably the asymmetry kind of got me thinking along those lines, and then the position of the middle turbinate on the right-hand side as it came off the skull base.
Okay, well, you're a better man than I, so I stepped in. So I guess you mentioned the idea of ectopic. I see, Raj, you were talking about the idea of, so can there be completely ectopic tissue within the nose that is not associated with the skull base or with the skull base defect? And can we talk about, well, why did this patient have if it's a congenital lesion, why this patient had no symptoms for, 30 years or however many years, and then what might have caused that decompensation so it starts coming out of his nose?
Right. Yeah. I mean, I don't have a good answer to it. Could it be ectopic? Anything's possible. And I'm only thinking that after the fact, appreciating that you said the skull base was intact and so on. Could this have been some sort of, collection of cells that eventually got infected, or like you mentioned, mucocele, something like that somehow precipitated this growth?
Yeah.
A year is kind of relatively soon acute, right? Like he's doing fine, like you said, until a year ago. So, I mean, it's definitely an odd case. I think the point of what you expect to see in a polyp patient is the key thing here. We expect to see symmetry. And encephalocele should come to mind whenever you see that type of asymmetry or other type of mass lesion. We're so trained to put everything together into one diagnosis, right? It's sometimes hard to focus yourself to not do that and leave the door open that there could be inverting papilloma or something else. So it's a wise thing that you mentioned to kind of make sure you have the full differential in mind.
Yeah, I think this is an interesting case just because for those of us who treat adult patients and don't think about the congenital defects and the anterior neuropore, it can be, glial contents can come from that. It may be that this patient had some sort of defect, as a child, and then maybe, it kind of sequestered inside of the nasal vault, which is maybe something you encountered. It's good to think about that.
Good. I want to try to get through a few of these, but I mean, we can continue discussion online, right? Okay. So this is always a fun situation in intraoperative consult. So I was operating overhead page. Hey, one of your colleagues would like an intraoperative consult. And I come in, and this is exactly what I see. I'm like, and he's like, well, what do you think? I'm like, well, you're going to have to let me know a little bit more. So it was a 40-year-old woman with Down syndrome initially, and who presented with congestion and rhinorrhea. And her previous scan was pretty, so this is what she looked like, just a couple, like about a month ago. He did an initial FES for this. And underwent routine FES, ethmoidectomy, maxillary antrostomy, approximately 4 weeks previous. Her symptoms improved for a while, then worsened. Then she was having some worsening appetite, low-grade fever, small amount of bleeding, but no pain. Pathology was pretty unremarkable. Showed a small amount of necrosis and colonization with staph, no fungus, not a lot of lymphocyte activity, and no vasculitis. Okay, and then subsequently, she took another scan, and she looked like this. And again, just a couple weeks later. So, So, any thoughts? What do we think we're looking at? I mean, anything come to mind? Not that you know. I have no idea at this point.
Did they resect the inferior turbinates at the initial surgery?
No, they're still there.
And the history of that drew her to the first surgery, was that a long-standing issue, or was that more of an acute issue?
Yeah, it's pretty long-term, months, and she did somewhat respond to the medical therapy, but not enough that she went ahead with the FES. So what do we think here? So Frozen's. So Frozen's at that point revealed hypovascular necroinflammatory debris, very highly acellular with bacterial colonization, a small amount of inflammatory infiltrate, negative for fungus or for Staph aureus. And of course, he was concerned, he's like, do we have invasive fungal sinusitis here? Do we have some immune occult compromise, and she's got this going on? And do we know what's going on? What do we next? Do we wake the patient up? Do we do an aggressive resection? Is there anything that can help us out here to figure out what's going on?
I think, when something's weird like that, the first thing that comes to mind is a vasculitis or some sort of inflammatory reactivity that might have been underlying and kind of set off by the stress response. Obviously, kind of strange things like a NKT cell lymphoma or something odd like that. But I think in this setting, I'm pretty, the vasculitis is to be concerned.
Would you do anything here? So you would say wake the patient up, or would we try to do anything else? Aria?
In these weird cases, I'd send for everything. So fungal PCR, the fresh lymphoma, formalin, tissue culture. If you need to get serology to anti-PR3, you could do that while the patient's asleep. But I think I think it's okay to wake the patient up and then kind of get more information, let the pathologist do their thing, and potentially follow that up with more imaging or more testing, consultations with rheumatology or your allergy immunology colleagues.
So
I would probably, remove as much of that debris that you can, just cleaning all of that out. And you can certainly have like a bad infection, like in the bone of the inferior turbinates. Like I can't tell that they're still there on that scan, and if they weren't removed at the time of the original surgery, you can get a severe bacterial infection that happens. Aria and I are talking about nasal picking as a possibility for some patients, that they can really induce a very severe reaction by doing that.
Amongst you all, I think you're on the right track. So specifically, the thing is to request flow cytometry, which they were able to do with 30 minutes while the patient actually was asleep. So, and that did show extranodal NKT cell lymphoma or lethal midline granuloma. Stacey, I thought you'd get this because you presented an NKT earlier today with your maxillary case. So the patient ended up getting, unfortunately not doing well. Palliative chemotherapy passed within a few weeks, but I think the diagnosis spared, a futile aggressive resection. And upon chart biopsy, she was having some other mild systemic symptoms that she was being worked up for, alopecia and intermittent low-grade fevers. But the takeaway is here is unless you're specifically suspicious for something like lymphoma, the pathologists don't really lead you down that path. They're not saying, oh, there's something here, get flow. Like I've never heard them say that. It's always been something that you have to initiate.
So I've had and one thing with NKT cells specifically, I've had a patient that I operated on that was presumed to be CRS and then just kept worsening, and a revision surgery within a few months then revealed it on the pathology, but when they looked at the original pathology, it was actually present there too.
Right.
Flow is not always positive in NKT cell because it's not a B cell lymphoma, which is what usually shows up on flow. And so for the pathologist, you have to alert them that you're looking for NKT cell.
Right. That was my point. You have to ask specifically. Yeah. You're looking for NKT cell.
And EBER stain actually is often positive in NKT cell, and a lot of times the flow won't actually reveal it.
Yeah, no, I had to specify that we had to tell them we were specifically looking for NKT cell because, the B cell would not have shown anything. So unfortunately, you have to have that level of suspicion. So moving on, this patient, so the VIP, I call this one. So it was literally his 4-year-old hospital board member and Microsoft executive, and he comes in with a history of frontal pain despite multiple courses of antibiotics. He was already signed up to have surgery with another surgeon. So I'm like, I feel like, oh yeah, bring it on, whatever you got, I can take care of it, right? Until I looked at the scan, oops. Uh-oh, why is it not doing the thing? There we go. Okay. So Craig, you're not allowed to pipe up too much about this one because I think I spilled the beans already. So what are we looking at there? Oops. What did you guys think? So I guess the money shot here, a good idea. So that's probably a good picture kind of there. So more of the question is management, so what would you offer somebody like this?
I think this is definitely a case. It looks like there's some probably a mucocele or some sort of obstruction from some high cells, whatever naming convention you want to use, but like a supra-ocular cell and probably a suprabular cell that are in frontal that are blocking that. I think for this, I'd want to probably offer both an endoscopic view. You might want to talk about an extended endonasal approach versus potentially a trephination or something like that to help get that area.
So what's your ladder as far as you talked about some, what is your, endonasal, and then you said some other approaches. What would be the next couple stages?
Yeah, so I mean, I think for this, I'd probably, I'd think about kind of doing that like half Lothrop potentially, that half like the extended draft 2B more or less, and then, but I would also discuss, potentially offering like, a direct brow approach or even a transorbital approach as an option, which I would go to for potentially accessing that.
Mo would be so proud.
He would be so proud. He'd be disappointed I didn't send it over there. Yeah.
So guys, how do you assess? I mean, is it just eyeballing it and just being like, whoa, geez, that looks really far? That's what I was kind of looking like, geez, that kind of looks like a long way to go.
Yeah, I mean, it's not just the long way to go to get to the top of it, though. It's what the goal of the surgery is, right?
Right.
So even though you have a big mucocele that's proceeding very cephalad, you
There's
just really have to
two.
marsupialize
Did you guys
it.
see there's two?
Two,
There's a lateral
midline and
too.
one more lateral. So I think examining the CT scan really critically, and in this case with the frontal disease, obviously a sagittal scan would be really helpful.
Yeah,
And-
sorry to show that.
Yeah,
but
that's okay. And so between sagittal, axial, and coronal, really trying to plot your plan as to how you would get there and how you would try to marsupialize it. And I think, you can try endonasal. And if it doesn't work, you could always come back another day.
Yeah.
I love the idea of a trephine. And I often will put trephine on the consent and explain it. Because if it's the lateral mucocele that you couldn't get to, a small trephine through a little, 1 centimeter or less incision, just to open it up from above into the frontal sinus cavity through a 2B, I think is a great thought. Might be all you need to do.
Yeah, I mean, I was literally sitting there measuring my instruments and like getting the ruler out and seeing like what does the angles look like. And so this is what I ended up doing. Sorry, the video got screwed up with this one. Oops, sorry. Oh, so he actually ended up getting that surgery with an outside surgeon. So I'm like, phew, not my problem. Awesome, right? But he comes back and he still has symptoms. And so I took a look and say, well, what's he look like now? So let's check it out. Let's see what this other guy was able to do. Doesn't look too different. So we don't need to really comment on that. So the thing to know, I was like, okay, all right. So the whole thing with that is he was like, well, he came back and said, well, I want this just taken care of. And unfortunately, my mulligan was kind of burned. I couldn't be like, well, we'll kind of take a look. And then it was like, I want this done. Even if you got to do the coronal approach, I'm in it. Let's do it. So this is what I ended up doing. So I did do a kind of a modified trephine. I actually did a bone flap. So a 1 by 2 centimeter beveled osteoplastic flap. I did go to the super and I mobilized it, but it was intact. And sorry, I have these janky images, but the video got compromised. But anyways, so that's what it looks like from the outside. So on the inside, you can see in the lower left-hand corner, we got a really good view through this transbrow bone flap, both the lateral and medial mucoceles, which we were able to drill out. And also, I was thinking that the time saving, I was able to do this in like 90 minutes. And then, so putting the bone flap back in, beveled it so we didn't have to use any mini plates or anything, just dropped right in, closed it up, and we were done. And this is what he looked like afterwards. This is at 2 weeks. And he was really happy.
Did you open up his frontal?
It's from below. I'm sorry, I did show it. That was what they're on the right. So, and there, I don't know if you guys noticed, but there was some osteitis from the previous approach. So I just put a little mucosal graft and it seemed to work out okay. But now I'm going to try stents more. So here's the thing, and I did warn him. The patient did have some numbness and neuralgia for about 2 to 3 months, actually, which I had to treat with gabapentin, 300 milligrams TID, but did resolve. And I think we touched on a lot of these things. So is there a role for hybrid or open endoscopic approaches in 2024? I mean, everything we see and we go to all these meetings and everyone's like, look what I was able to do from down below. And we're like, whoa, I can't do that. And glad, Raj, you're going to say, hey, I do this. But I don't just, when we go to these meetings, I just don't hear people talk about it. I mean, is that?
I mean, generally the rule of thumb is whoever does it with the fewest incision wins, but I don't know when you win. So if you're not in it to
gray
win,
hairs,
from
or no
reputation
hairs,
standpoint, why wouldn't you try it, right?
Yeah.
And I think, especially the population we sometimes see this in is less this demographic, but an older patient that has a lot of comorbidities. If you can pop a trephine and save them an hour under general anesthesia, you probably did the patient a big favor. One other thing that came to mind as you were showing that image is that, when you have multiple mucoceles, you can really use your navigation to your advantage there. And the thought is you want to almost have a sense of how much mucus you anticipate draining from the frontal sinus, and make sure that the tip of your navigation probe, even if you're going from the open approach, is in the center of each of those three cavities. Because, it's very easy to get a whole bunch of pus out and you think you've done a great job, and you might, think that you've gotten the mucuses, but you really want to make sure that the tip of that probe is showing that you indeed have marsupialized and connected those three spaces that you showed.
And all your ledges are gone and looking good and all that. So
I just want to say one
please.
thing, just because, so 3 of us trained at the same fellowship, I'm realizing, and we all, I think, love doing like an osteoplastic flap. It might not actually come up that often, but I think it is really important that we continue to actually teach what that operation is and be able to do it, just because there are going to be times that you can't do something endoscopically. And I always get really excited to talk about frontal sinus if I'm asked to talk it, because that's what I always end with, is that there are times that you actually have to do either a combined approach or really just go straight to doing an osteoplastic approach, because it's the easiest thing for the patient.
All right, last comment, then we'll give it more try to
I
squeeze
think,
it more.
I think the interesting thing is, you talked about the coronal and the coronal as a way to get to the osteoplastic. I like that. I often do that direct brow incision as well, which heals beautifully. It's super easy to get there. You don't have to spend an hour suturing them up or stapling at the end, and they have no scars. So.
Yeah, and don't shave the brow. Right? Don't. Did you do? No, don't. No. Actually, I did like a cosmetologist, and she was really happy. So, anyways, next case. This may seem like a boring case, but isn't. So, transfer care from retiring ENT. 38-year-old woman with a history of nosebleeds for the past two years, worsening over the few months over the winter. I'm sure you guys never seen any patient like this ever, and I'm sure you're getting excited just hearing the history, right? She ended up seeing an ENT and having annual cauterizations, no blood thinners, no known bleeding disorders, no blood transfusion, no family history of nosebleeds, no hypertension. Uninteresting, right? So this is what she looked like inside. Well, that's odd.
Vince will try to keep this case to.
Oh, yeah, this is,
selected points.
yeah, I see that, yeah, 3 minutes, yeah, got it. Okay, what do you guys think?
It looks. I looked. I couldn't tell super, but it did look like there were potentially little mounds of. HHT would definitely be something I'd be concerned about, but.
In a 38-year-old, no primary, no.
It certainly can progress, and you don't always see it early on, but I think that'd be. I'd want to see what was bleeding and kind of get a sense, and then discuss treatment after that.
Is it bleeding from both sides? I would probably want to see which side it's.
Yeah,
okay.
but not really very seriously.
And then any other like systemic symptoms? Like,
Nope.
Is she on any medications?
Nope. So I'll move on. So basically, here's the thing. And look at her lip too. You can see she's got those. So it looks like HHC, but how? Again, bleeding's not severe. Patient's almost 40. It's autosomal dominant. No first degree relative to HHC. What the hell? What do you have? What do you have? And she's very upset because I brought this up. She's like, unclear whether she has this multi-system inheritable condition. And she's trying to conceive, like, what can we do to help this patient out, to figure this out?
Genetic testing.
There you go. So genetic testing did show that she had defect in ENG gene, and also that her paternal background was in question.
Oh.
Yeah. So I didn't have that talk with the geneticist, had that talk. Yeah. So it's really important to make the diagnosis of family planning systemic. She ended up having a liver lesion as well, but she didn't have one in her brain, thankfully. So even though we think of it most often diagnosed early in life in the 20s, but it can be as late as 40s. Actually, I had one case, a patient in the 60s. Have you guys had any experience, and I guess the last question, if you guys had seen this, because we classically think of these patients who, because they have this family history, they get diagnosed very early, their bleeding is very severe, but have we seen these patients who don't really have that severe of clinical bleeding, but they got it? Have you any? Oh,
Yeah.
so Stacey's nodding, so all of you guys.
Yeah.
I mean, so it was kind of new to me, so I thought maybe new to these guys. So good. So we can probably wrap up with a minute left, I think.
Great.
All right.
Open it up in the last minute.